and welcome to the Home of Medicine podcast, a podcast in association with the European Federation of Internal Medicine. My name is Dr. Amy Burbridge. I'm a consultant in acute and general internal medicine in the United Kingdom. Today's episode, we are going to do something completely different. We are going to talk about longevity medicine. And I am very, very honoured to welcome a good friend of mine to this podcast.
Thank you so much, Amy, Dr. Burbridge. My name is Ewelina Biskup or Evelyne Bischof. I have been indeed a long friend of Amy and a long friend and member of FEFIM, the European Federation of Internal Medicine. I'm an internist, splitting my time between Switzerland and China. Taking a little bit of an unconventional path, which also led me to longevity medicine. And I am a consultant, a chief physician in internal medicine department and medical oncology at the Renji Hospital, Jiaotong University in Shanghai, and associate professor in the Shanghai University of Medicine and Health Sciences. At the same time, I'm affiliated with the Center of Multimorbidity of the University of Zurich, and as of recently, also associate professor visiting at the Tel Aviv University and the Shiva Medical Center.
Wow, that's a lot. Incredible. Thank you so much. So thank you for finding the time to join us.
Thank you so much for having me.
Oh, the pleasure's all mine. The first question, and I'm sure all our listeners will want to know, what is longevity medicine?
Thank you so much for this question. And I love to start with that, since on the one hand, it's important to know that we do not claim to have an official definition yet, but it's very important to know what longevity medicine is not all about. So longevity medicine, as we tried to comprehensively encapsulate it in our article in Nature Aging last year with Professor Kai-Fu Lee, who is the godfather of AI, as one may say, and Professor Alex Javaronkov, who is the godfather of deep aging clocks and AI-based drug discovery and repurposing, and myself. We defined longevity medicine as precision medicine that is AI-driven and is targeting the health span extension, meaning AI-driven precision medicine that based on measurement of the biological age of an individual person at a specific point of time, tries to then find biomarkers and identify trajectories to firstly identify the biological age of the optimal performance of that specific person at that specific time, and also give a set of further parameters that should be adjusted in order to restore the current biological age to the optimal biological age of the patient in order to achieve the optimized or the optimal individual performance. So that would be the comprehensive definition of longevity medicine. As you can see, it is not about extending life. Our reactive medicine, as we know it, is already doing that and has been doing that already for many generations. This is why we are facing the silver tsunami. This is why we have massive percentage of people that we would now call population of geriatric patients, or in general, oldest old. Which do not always mean that they are frail, which do not always mean that they are affected severely by age-related diseases. But as we know, most of us will, and most of those people in this sector of population are affected by those diseases. And so longevity medicine can also be defined by its aim. And the aim and the main objective is really not only to restore this biological age of optimal performance, but what it also means translated into our terms, it means to extend the healthy lifespan, to extend the health span, meaning identify risks, mitigate them, optimally also eliminate them so that the person, as he or she goes through the life journey, meaning also aging and declining, will not be affected, or at least not strongly affected, by age-related diseases.
Okay, so if I was to come then to you as a patient, for example, and my biological age is obviously 25, if only, but so my biological age is 42. So how would we then assess my optimum performance age?
That's wonderful. So let us go back first to the definition of biological age. Maybe that's also very important to illustrate. The biological age is not our chronological age. So our chronological age, the one that we have in our passport, if we didn't lie at the authorities, is is what we know, what we are calculating, right? That's our chronological age. Our biological age might be totally different. For most of the people, hopefully it's less than the chronological age. For some people, it's more. And there is already an abundance of markers to calculate the biological age. And all those markers, of course, are also potential targets for therapies or strategies on how to either decelerate the aging process or optimally also to partially reverse it. We can talk about it a little later. But again, I would like to underline that longevity medicine is not about living forever. That's transhumanists, that's not us. Yeah. Longevity medicine is really extremely scientific and highly interdisciplinary, not only within medicine in general, but also combining. So for me, longevity medicine combines three fields. Number one is medicine, as we know it, the clinical medicine. Number two, AI science, because we need that very much to really derive trajectories from big data sets, create algorithms, program them, and so on. And then number three is gerosciences. So the bench-based research, the basic research that is allowing us then to further translate it into the clinical practice. So if you were my patient, and by the way, myself, I'm very biased. So for me, aging per se is a disease. That's also a very big debate among the longevity specialists and well, myself, I think aging is a disease, and therefore I call everybody a patient, including myself, right? So that's just to underline that if a person comes and would like to have his or her biological age measured first, right? So for this, I would use a variety of so-called aging clocks. I personally like to use the deep aging clocks, meaning aging clocks that are based on deep learning methods, like advanced methods of AI. We all learned in the med school about the very first aging clock that was at that time still not AI driven. That was the Horvath's clock, right? In 2013, Stephen Horvath was the first and sole author on the publication where he described the first biological clock. Well, ever since, AI augmented tremendously and newer technologies were developed. So those biological aging clocks are measuring biological age based on different samples. So one can measure it in the blood, which I like a lot and do a lot. And also one can measure the so-called epigenetic. One can use epigenetic clock to measure the biological age based on that, which is basically the DNA, right? And then there is also a number of other clocks, such as microbiome-based clock, such as physiological aging clock, such as subjective aging clock or psychological aging clock, based on an abundance of questionnaires that were validated in terms of the mental health of a person, and also let's say, self-awareness and self-experience of aging, and photo-based aging clocks, based, of course, on algorithms that are, scanning the skin, scanning the face, and so on. So I do like to apply almost all of them. Some of them need to be done pretty much just once a year. The blood age I'm doing quite frequently, every 3 months, depending on what the person is actually doing to change the biological age. But those are those things, right? And then I apply another technique, or of course I outsource everything. I don't do this myself. There are people who are doing this. I don't have a little, thing in my attic, but I wish. But so there is there are outsourced partners and collaborators that can create so-called age metric that will allow me as a physician to learn about what is the optimal biological age of that patient, and that would be basically the AI that will provide me that output. And then the AI will also provide me with the output, which parameters are making the patient younger or older biologically, and what is the optimal value of a specific parameter, so that the biological age will be best for that patient, right? So we are moving very far away from what we are used to in the hospitals or in the practices, where we have our ranges of the parameters, the normal value range, right? Yeah. Based on studies and RCTs in the 60s. And so we, and absolutely not diversified and differentiated, not even for sex and gender and age groups. But here it's an ultra optimal approach, not only two-dimensionally, so for the person and then what is the sample, right? But also the time. So it's like three-dimensional, and that's something very important. Why? And I will. I'm sorry, I'm getting so excited when I'm talking about it, so it's very hard to stop me. But I promise.
Can I just I've got one question. So you said that you send the blood test off every 3 months. So what are you actually looking for in the blood when you do these tests?
Yeah. So I personally, I do always, number one, always an individual set of lab parameters that I need for that patient, but they do always include the basic 45 parameters that are necessary to calculate the biological age. So there is a base, and then I close this base with further parameters. Yeah. And why do we make it often? Because and why is it important? Because we are measuring for that specific patient at that specific time. So we need longitudinality in order to make better predictions. So the more, the better. That's generally the rule in terms of testing, not in terms of therapeutics, and in terms of biological blood age, not so much about other tests. And yeah.
Okay. So are these blood tests that I can do in the hospital? So is it full blood? Okay.
Absolutely. Yes, absolutely. So these are the parameters that we all know and we all work with. There's nothing extraordinary. And it's just that the AI was able now to identify them, and it's not only about the actual value of those parameters, it's about their interactions, right? So it's 45 times 45, and then adjustment for a person and so on. Yeah. That's why we need the AI. The human brain cannot do that.
Oh, it's really interesting because we are so used to doing, for example, a full blood count, looking at a hemoglobin level, and there are very strict parameters, aren't there, within a hospital setting and within the, the general population, where a female should have a hemoglobin range of 120 to 150, for example. And that's it. And there's no individuality in that. So I am compared to somebody who is 18 and somebody who is 80. So the longevity medicine is very interesting, that it's very personal, isn't it, to that particular, that individual. And that's really important.
Yeah, it's going, as to say, in the tunnel from as we said, let's say we have precision medicine, and then we have the next stage, which is the individualized medicine, right? So that's pretty much where we are. Yeah.
Yeah, and I think what we do as well, and certainly in the UK, what we do a lot is we check, for example, blood pressure, or we check creatinine, protein creatinine ratio, and we may diagnose that person with chronic kidney disease stage 2 or hypertension. And there's no individuality. We start medication according to age. We may start amlodipine, we may start an ACE inhibitor, ramipril, 2.5 milligrams, regardless of really gender, comorbidities. A little bit of age may go into there, but we usually start the same treatment. And obviously some people react very well, some people have really bad side effects, it doesn't respond, in some people. And I think it's really interesting that actually, it's certainly in hospital, when we are seeing many, many patients, we aren't actually that individualized, because we can't be.
Absolutely, and you are bringing something that is extremely important. So while I am, for example, discussing longevity medicine with the colleagues from other fields, so not physicians, there mostly we are focusing on people that are, as to say, healthy by the standards, or no obvious disease there, and there we are talking just about the optimization, about tracking everything. So in longevity medicine, we are tracking everything, and from all the parameters, vital parameters, 24/7, to the blood oxygen at night, to apnea scores, to CGMs, like continuous glucose monitoring, to ketonic values, intermittent fasting values, outputs, electrolytes in the saliva, the vision, the photo every day. Plenty of data. And then every now and then we make a comprehensive check, which is giving us 150 gigabytes of data and more, right? So we are going into the entire genetic, and not the general genetic, but also polymorphic risk scores. We are going into 4 Tesla MRI to identify aneurysms years in advance, right? So all those things, liquid biopsies, and continuous tracking. So that's something we do. And while we are focusing on that, we are forgetting that we physicians, we are not used to that at all. We are used to the reactive medicine, where we have to deal fast. We see a lot of patients in the hospital. Individuality cannot be really that much accommodated. However, I believe, and I think we mentioned this before, like, where is longevity medicine standing, and does it really matter for the physician in general? And I think yes, very, very much so. I think we see that already pretty much with the pathologists and radiologists. They are already AI augmented. They work with an AI augmentation in whatever they do. And I believe, especially as internal medicine specialists, including intensivists and those who have to work with multimorbidity, with complexity, with comorbidities, and with differential diagnosis, and with patients who will more and more experience external education on how they can track themselves, and will bring up and demand that the doctor will look at their data that they collected. I think we all will, at some point of time, be obliged to use some sort of AI support and augmentation. And so I see longevity medicine being a fantastic, great support when it will enter the clinic, because it will give us the opportunity to really precisely not only diagnose, but then also to treat the patient, in all disciplines.
Yeah. And it's so interesting that it's crazy that we're in 2022 and we still aren't, I guess, utilizing this more. I mean, my one concern about this is it sounds like there's a huge amount of investigations, is the cost. And somewhere like in the United Kingdom, where we are a publicly funded service, we are very, we don't have much money at the moment in the National Health Service. I was wondering, to do actually implement all this is a huge thing. Is there can we start small? Is there something we can all do as internal physicians to help introduce longevity medicine?
Yes, absolutely. And what a fantastic question. And actually 2 points there, right? So number one, about the costs. Mm-hmm. So we know that our systems are not exactly the biggest funds that are out there. So luckily we are seeing, number one, a decrease in costs for most of the tests. So when we even look at the genetic testing, now, so we went from thousands to hundreds to now actually, a few dollars, if you may, in some of the countries, right? So we will see, I think, the decline of the pricing for some of the tests that are crucial. Yes, I agree that some of the imaging technologies are still quite expensive, but we have also seen a massive reduction of those. For example, in places where I work, they are now, a full body MRI for about $100. That is something that, yes. And in university hospitals, I know that's different in Switzerland and in the UK still, but I think we will see this trend coming. So I think technology will be more accessible for the humans in general. That's number one. Number two, once the systems will actually see and agree that this approach is actually leading to massive savings, then I believe they will be more prone to apply and integrate them in the systems, since it's ridiculous what kind of money is being spent on long-term chronic diseases and comorbidities, right? So, and we see, and it's extremely frustrating even for us physicians to see that the hospitalization duration and this and that. So I think we all know that this is another point. So I think it will be more accessible, it will be cheaper, and also people will be less judgmental, or maybe less fearful. Technology and AI, that's not something for everybody. There's also a lot of misinformation, and when you say, okay, we will do some AI-based testing, or we will collect some data, some people are already so burned on that wording that they are not very much willing. So, but there are good studies showing that societies such as China, for example, again, I'm very biased and I'm very xenophilic. So China is showing the main maturity of the society towards AI, right? So we live AI day and out. And this is where longevity medicine is prospering, for example, right? And also the government has recognized its importance. So in this 5 years plan, it's integrated as one of the priorities. Yeah. So we see that the public health is recognizing that. And this is number one. Now to the second part of the question, what can we do with the small steps? I think number one, we need to learn about it. It's something that is not very prominent. So I'm so grateful for this podcast, for example, as well, because there is a huge amount of information and a very vivid and great debate on a fantastic scale on this, among the scientists, geroscientists, and also AI specialists, investors, or all those groups, but not among physicians. We do not have too much time to learn that. We are not taught at school about this. And so this is, for example, one of the reasons why myself, I was very honored to develop a course on longevity medicine for physicians, actually a course series by now. There is an introduction course, there is an advanced course, there will be more courses, there will be a clinical course, it's CME accredited. And it's for free, because we want physicians to learn from credible sources about longevity medicine so that they can then apply at least some of those things. And they will see patients coming already with those apps, with those data collected. They will see that there are other diagnostic tests that can be given to the patients besides, for example, I just give a random example, right? instead of a colonoscopy for a patient that we know is, for example, thrombophilic, whatever, after chemo, but is in great need of a colonoscopy. Why don't we use liquid biopsy? Why don't we use the stool test like Cologuard, that in America is already FDA approved as an alternative to colonoscopy for cancer screening, right? Why don't we have that as a common knowledge, number one? So I think number one is to learn. And there is also an article in Lancet Healthy Aging that we wrote about upskilling longevity physicians on how to educate longevity physicians. I urge everybody to have a quick scan on that. It's very valuable. And then there are small things that a physician can already do. For example, with all those patients where we are trying to bring them from the state of massive comorbidities to a little bit of a healthier stage, here you can already apply, for example, very simple free aging clocks. It's the photo-based aging clocks. You can apply already some of the trackings that are on a low cost or zero cost. Most of the apps are actually accommodating tracking that are for free. You can already apply of those newer technologies of diagnostics that will create longitudinal data where you do not really need so much the accuracy, but the trends. So for example, a lot of my patients are doing a daily body scan on a very simple scale that costs €5, but I have the trend, right? I do not need the accuracy. I need data every day. So all of those things can be applied. Again, longevity medicine is not only a field right now, even right now for the wealthy. It's pretty much accessible for everybody. Yes, there are scales and there are ranges, but the basics are available. And I think also the more advanced diagnostic and then hopefully later on the therapeutic arenas will be accessible for all.
And can you just tell us the website for your course, please? And I will also put it into the show notes as well.
Oh, absolutely. So if you Google Longevity Education Hub, you can find us there, or you can go to our very simple but very comprehensive website, longevity-medicine.org. And there you can find the links to all the courses. There is a link to the Teachable platform where the courses are fully free. Previously, we were also on Udemy where they still hold the course, but I would urge everybody to go to Teachable and take it for free. And those who are physicians and have passed the quiz after the course are entitled and will receive not only the certification of the course, but also CME accreditation from the American Medical Association, the AMA.
Fabulous, thank you. So I've got one final question. Is it possible to turn back the aging clock? Will I ever be 25 again? You know, it's
definitely possible to turn back the biological aging clock.
Okay.
To which extent, that's very individual. And trust me, you don't want to go back to 25. But it's definitely possible, and we see beautiful examples. Yes.
Fantastic. Thank you so much. I could talk about this all day, and I do know that hopefully in the future we will also record some further podcasts, and hopefully we'll have a series on longevity medicine and we can go into it in more in depth as well. But I think this has been a fantastic introduction into what longevity medicine is. Can I just ask you then to give us your key takeaway points for our listeners today on longevity medicine?
Sure, with pleasure. So first of all, thank you so much for having me here and giving me the opportunity to speak about this field that I am so extremely driven about, and where I would love my colleagues to learn about it, and those who are excited to also join the field. So one does not have to only be a longevity physician. As I mentioned before, it's integrative. I am still in the reactive medicine, in the sick care, as to say, but also I'm in longevity medicine. And I think the core messages here, let's say there are three. Number one is it's worth learning about longevity medicine. That is one of the most scientific discipline that I have experienced in my life. And those who know me know that I like being very pragmatic and scientific. Number two,
absolutely.
Number two, longevity medicine is a new field. It's an AI-based driven or AI-founded precision medicine. It does include various disciplines of clinical medicine, but it is not transhumanistic extension of life discipline. It is not functional medicine. It is not naturalistic or holistic medicine. I would like to make very sure that this is being discerned it's also not wellness, and it's not only for the wealthy. And number three, I think it's very useful to follow at least some of the main papers that are coming up in journals called Nature Aging and Lancet Healthy Longevity. Those, I think, are the two most credible sources, also Cell Aging, but the Lancet and Nature are more for the physicians. And also, of course, welcome to join our course, have a look at it, listen to it, hear about it, and welcome to ask any questions if you like through the contact forms there.
Fantastic. Thank you so much. And I think the key thing for me, and it's music to my ears when anybody ever says this, it's all about education. And, educate, because we can't practice longevity medicine if we don't know what it is. And, I've done the course, and it's really brilliant, and it's really interesting. And I didn't really know anything about longevity medicine before. So I can highly recommend it. And also, we will have some more podcasts in the future, so keep your eyes peeled for those. And a massive thank you again. Thank you so much for joining us today. And we will have you back on very soon. Have a good day.
So much. Thank you so much. All the best, everyone.
And if anybody's got any questions, you can email at amy@efimacademy.org or tweet me at Amy Burbridge. Thanks for listening. Goodbye. You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.